Take a deep breath. You know more than you think. Today isn't just about the exam, it's about sharpening the skills you'll use to save lives. This is the final push towards becoming the doctor you have dreamt of being. Let's clear the fog, lock in the essentials, and get you ready to crush this. You have got the talent, I have got the high heels. Let's do this. Today's topic is varicose veins. First definition. Varicose veins are dilated, tortuous, and elongated superficial veins which are caused by incompetent venous valves. That means usually the valves are one-way flow, but here they become two-way flow, which leads to venous reflux. This is what we just said, that instead of going only one way, it goes the other way also. Now this causes venous hypertension and then dilation and then complications. For classification, we have two types. First is the CPOS standard classification and the other is the simpler or older grading. You can remember whichever you want, but CEP classification is the standard. First we'll see the simpler or older grading. Here grade 1 is mild telangiectasia or reticular veins. Grade 2 is moderate varicosities without edema. Grade 3 is varicosities with edema, pigmentation or eczema. Grade 4 is presence of ulceration. It may be active or healed. Now here I am attaching the image of the CEP classification which I have given in my mind map. You can download that mind map from the link in the description or pinned comment. Pathophysiology. In normal human being, blood flows from superficial veins to deep veins and then to heart via competent valves. But in varicose veins, due to valve incompetence, there is reverse flow or reflux, which causes venous hypertension and then venous dilation and valve worsening. If the cycle continues, it causes skin changes and ulceration, causing deep vein damage too. Clinical features. Symptoms. There is aching, heaviness, fatigue, which is worse after standing, relieved by foot elevation. Usually there are night cramps and cosmetic concern. Coming to signs, there are visible tortuous veins, pitting edema, eczema, pigmentation, lipodermatosclerosis, ulcer near medial malleolus or gaiter area. Clinical tests and interpretation. First, Trendelenburg test. It assesses saphenofemoral junction incompetence. If there is rapid filling after release, it means test is positive. Next, Perthes test. It checks deep vein patency. If veins collapse when walking, that means patent deep veins. Third, multiple tourniquet test. It localizes incompetent perforators. Segment filling means site of perforator defect. Schwartz tap test. Transmitted impulse felt proximally means there are incompetent valves. Investigations. Duplex ultrasonography is a gold standard. It is used to visualize reflex and obstruction and map incompetent veins. Next, Doppler flow study. It detects the direction of flow. Next, venography, which is rarely used now. It is used when deep system pathology is suspected. Management decision flow. This depends on the grading of the varicose veins. If it's mild, that means C1 or C2 grading, we use compression stockings for the venous hypertension. And if there's cosmetic concern, we do foam sclerotherapy, which is an OPD procedure. And if there's SFJ incompetence, we do ligation and stripping. If there is perforator incompetence, we do SEPS. If there is ulcer, C5 to C6 grading, we do SEPS plus compression. If there's deep vein block, we avoid surgery and treat the cause for deep venous thrombosis first. And if the patient is medically unfit for surgery, we do only conservative treatment. Now, if you are aspiring to become a topper and want to write this management in detail, then I'm attaching this photo, which is also there in my PDF, which is available in the link in description or pinned comment. Complications. Local complications include pain or heaviness, eczema, pigmentation, lipodermatosclerosis, ulceration, bleeding, thrombophlebitis. Systemic include recurrent infection, edema, and poor wound healing. Prognosis. Primary varicose veins are excellent after correction. Secondary, or if deep venous system is increased, there is guarded prognosis. And recurrence, it has 10 to 15% recurrence for missed perforators. These are the mnemonics for revision. You can read this, just to revise what all we have studied now. And since we have explained everything in this video with subheadings, I think it is useful for you from ultra short to essay to cover whatever aspect. I hope this helps. That's how you handle this topic like a pro. Take a breath. The hardest part of the journey is already behind you. Now, go show that examiner exactly what you're capable of. I believe in you, and soon your patients will too. Go get them. All the very best. This is White Coat Edge, your edge in clinical mastery from the desk of Dr. PM.